Peace, gratitude, and highest heart love for being here. Welcome to the YouTube live book reading of Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. I wanted to make sure I represent. This is Friday's reading, Juma. Got the word that the goddess queen has elevated Asada Shakur. So we want to say a highest heart love and honor to all the family, friends, students of the great, incomparable Asada Shakur. Dedicate these readings to our ancestors and elders always that came before us. That's a part of being honorable. So we pick up in the middle of page 268. This is episode 46. I'm your moderator and narrator, Uriel Neveu Riley. Highest heart, love, and honor for being here and reading books with us. All right, here we go. Lung collapse. The insertion of a large suction catheter into a small diameter artificial airway results in inadequate space for air to readily entrain around the catheter. Thus, when a vacuum is applied, the lung may collapse. This is avoided by using a catheter whose diameter is smaller than the radius of the artificial airway. A rule of thumb is that the suction catheter should not occupy more than one half the internal diameter of the tube being suctioned. The suction catheter. The ideal suction catheter would 1. Be made of a material causing as little trauma as possible to the tracheal mucosa. 2. Have minimal frictional resistance passing through the artificial airway. 3. Be long enough to easily pass the tip of the artificial airway, 20 to 22 inches. 4. Have smooth, molded ends to avoid mucosal trauma. And 5. Have side holes to prevent mucosal trauma. The proximal end must have an opening that allows room air to enter and neutralize the vacuum in the catheter without turning off the suction apparatus. This allows the vacuum apparatus to remain on without subatmospheric pressure being transmitted to the catheter. Top of page 269. Peace, highest heart, love. Thank you, Emerald. And all the book lovers community, we're here for the people reading MCAT material where I will put the vocabulary in the description when I complete. Thank you so much. When suction is desired, the proximal hole is occluded with the thumb and the vacuum transmitted to the catheter. The proximal hole must be larger than the internal diameter of the catheter to prevent the Bernoulli principle from creating negative pressure when the hole is unoccluded. Sterility of suction catheters is essential. We believe that only disposable catheters should be used. The packaging should avoid curling so that removal from the package is easy and the suctioning process facilitated. The adult left main stem bronchus originates from the trachea at a sharp angle. Straight catheters enter the left main stem bronchus less than 10% of the time, regardless of head position. When left bronchus suctioning is required, Code suction catheters may be used. These have a curved tip, which facilitates easier passage into the left main stem bronchus. Mucosal damage from suction catheters, the middle of page 269. Autopsy findings in patients who received several days of tracheal suctioning reveal a high incidence of severe mucosal damage, hemorrhagic, and edematous. Oh, edematous mucosa is common. Sometimes the area is completely denuded. Fiber optic bronchoscopy has provided the means of observing the pathogenesis of these lesions. It appears that the mucosal hemorrhages and erosions are due to suction catheter trauma. Even with meticulous technique, this damage occurs consistently. Yeah, that's very big, right? That's very key. All right. In the middle of page 269. Some suction catheters elevate the mucosa when vacuum is applied and invaginate the mucosa into the side or end holes of the catheter. These mucosal areas immediately become hemorrhagic and may erode. Vacuum in excess of 120 millimeters Hg facilitates this process, but even proper suctioning levels of 80 to 120 millimeters Hg do not eliminate the process. Catheters made with ring tips or additional side holes seem to play a significant role in preventing such mucosal damage. The relationship between mucosal damage caused by suctioning and the incidence of tracheal infection is still in question. It would seem obvious, however, that the less damage one does to the tracheal mucosa during the suctioning process, the better it must be for the patient in relationship to comfort and possible infection control. Yes. All right. Suctioning technique. Sterile technique must always be followed. This entails the use of a sterile glove for the hand that will handle the catheter, the use of a sterile suction catheter, and appropriate sterile rinsing solutions and container for clearing the catheter. The catheter must never be stored and reused for suctioning an artificial airway. Ding! We're getting back to the cleanliness, right? Very key. Never used again. All right. So make sure when we're taking notes on this, for all those in the playlist and MCAT aspires, reps, techs, and everyone learning about this, it says using the following procedure, the incidence of complications and mucosal damage will be minimized. All right. Step one, adequately pre-oxygenate the patient. This provides the greatest degree of oxygen reserve in the alveoli. All right, see, that's very key. There we go. That's step one. Pre-oxygenation may be accomplished by hand ventilating with 100% oxygen or increasing the FiO2, right, to the spontaneously breathing patient. Some ventilators have mechanisms for giving 100% oxygen prior to the suctioning process. The pre-oxygenation step will usually avoid arterial hypoxemia for appropriate suctioning periods. Peace, highest heart love. Thank you so much. Oh, highest honor and heart love. All those aspiring, right? Clinical application of respiratory care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. This is the peaceful part of YouTube where we read books and learn from masters. So, gratitude and highest heart love. We just completed step one. We are in chapter 16, maintenance and extubation. Step one, airway care, section four, page 270. Step two, insert the catheter without vacuum until it is obviously past the tip of the airway and approximately at the level of the carina. When a slight obstruction is felt, the catheter must be pulled back slightly and then intermittent suction applied while rotating the catheter between the thumb and forefinger during removal. This rotating movement and the intermittent suctioning minimize mucosal damage and aspirate secretions more effectively. Very key. Thank you so much. Peace and highest heart love. Man, that's awesome. Oh, highest heart love. That's right. We are the light workers. We are the healers of the world and, the superheroes, right? So that this is what the work we do. Give it out for free. Love on the people, uplift us, give us self-healing mechanisms and modalities and teach them to the world so they can heal themselves and the people and family, loved ones, beloveds around us, right? That's the way to go, right? Yeah. Love. Step three, do not leave the suction catheter in the airway for longer than 10 to 15 seconds. The total time from the beginning of the suctioning process to reestablishment of ventilation and oxygenation should never exceed 20 seconds. The electrocardiographic monitor must be watched during the suctioning procedure. With the onset of arrhythmias or other patient distress, the process must immediately be discontinued and the patient ventilated with 100% oxygen. And we also know why to do this, right? Because arrhythmia can happen on the expiration part, right? Oh, look at it. Oh, highest heart love. Yes, the peaceful part of YouTube where we read books and learn from masters. I'm master fitness trainer Uriel Neveu. And so this is what we do. Light workers unite, right? All the superheroes. We're this is what this channel is for. All right. Step four. Reoxygenate and ventilate for at least 5 deep breaths. And return to baseline vital signs before repeating the suctioning process. The 4 steps should be repeated until all secretions have been aspirated and the airway appears clear. Following tracheal aspiration, the same catheter can be used to aspirate the oropharynx and the nose, but must never be reused in the trachea. Suctioning should never be done routinely. Some evidence of tracheal secretions should be present, since unnecessary suctioning may irritate the mucosa and stimulate secretion production. That's right, because the body's going to try to produce more. If you're sucking it out, the body's going to try to produce more secretions naturally to get it out. So that's why you don't want to keep suctioning, right? Only for limited periods of time. As it says, do not leave the suction catheter in the airway for longer than 10 to 15 seconds. So those are taking notes on this and just the mental notes and for in the replays and playlists. Hi, it's Heart Love. Obtaining culture specimens. Routine artificial airway care includes the obtaining of tracheal secretion specimens for culture and sensitivity. The frequency of this routine varies from institution to institution. However, the respiratory care practitioner must be familiar with that institution's method of obtaining such a specimen. There are various sterile specimen containers that are easily attached to the line of a suction catheter. Following the normal sterile suctioning technique without rinsing of the catheter, a specimen is obtained. We obtain our best specimens after ultrasonic treatments and postural drainage maneuvers. It is our opinion that tracheal aspiration for culture should be obtained at least every 3 days for patients with artificial airways. In addition, cultures should be also obtained if the secretions change in color, consistency, or amount. Of course, one must change these guidelines for chronic or permanent artificial airways. All right. The middle of page 271. Hi, it's Heart Love. Welcome, welcome, YouTube. Yeah, yeah. And we're in the maintenance and extubation, dealing with airway care in the fourth section of this book, clinical application of respiratory care. Yeah, this is a long one, very long one. And we're doing it live. So there's no commercials. And then I'm going to put them in the replays. And I also put the vocabulary in the description. It's a lot of super high level vocabulary that we can meditate with, right? And as well as learn more about and then help others around us. That's the goal, right? Heal the people. Humidification of the airway. A patient with an artificial airway does not have the ability of the upper airway to heat and humidify the inspired air. This heat and humidity deficit must be provided by the tracheobronchial tree, unless otherwise provided. It is essential that the gas delivered to an artificial airway be 100% humidified at body temperature. Without appropriate humidification of the artificial airway, the incidence of obstruction caused by drying of secretions will be great. With appropriate heating and humidification of inspired gas, the incidence of crusting and obstructing of the airway by secretions is extremely rare. For the spontaneously breathing patient with an artificial airway, an appropriate device to provide oxygen and humidification is a heated nebulizer and T piece with a reservoir tubing on the exhalation limb. This provides a high flow system, which will allow complete control of humidity, temperature, and oxygen without adding resistance. In the longer term patient or in circumstances where oxygen therapy is not critical, such devices as tracheostomy masks may be used. Failure to properly humidify the inspired air will result in dried, retained secretions within the airway. The importance of humidification is dramatized by the following case history. All right, here we go. Taking note, patient notes. A 27-year-old woman was admitted to a hospital with an original diagnosis of a stroke, which we just took care of yesterday, right? In a year heal in our year healing session. Oh, he's getting so much better. Oh my goodness, it's so amazing. I love, oh, definitely a goat healer. A 27-year-old woman was admitted to a hospital with an original diagnosis of a stroke. An endotracheal tube was placed because of upper airway obstruction. 24 hours after insertion of the endotracheal tube, the diagnosis of drug overdose was made, and the patient was transferred to our hospital for intensive respiratory care. She arrived in our emergency room 26 hours after intubation. For that entire period, there had been no humidity added to the inspired air. She was noted to have signs of partial airway obstruction, and a suction catheter could not be passed through the tube. Upon removal of the endotracheal tube, there followed an almost perfect cast of the main stem and segmental bronchi, figure 16.1. This was a thick rubbery material composed primarily of dried retained secretions. Upon extubation, the patient's respiratory distress was dramatically cleared. Yes, solutions. Yes. Now, here we go. This is 16.1. Cast of tracheal bronchial tree removed with extubation. Look, dried secretions. Figure 16.1, top of page 272 of Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout, second edition, 1979. So as you see, it says the cast of tracheal bronchial tree removed with extubation. There used to be great concern for the frequent changing of artificial airways and the cleaning of inner cannulas every 3 or 4 hours to prevent crusting. Since the understanding of appropriate humidification and its role in maintaining airways, we seldom find problems with crusting or obstructing of the airways if humidification equipment is functioning properly. There should be no reason for routinely, routinely changing artificial airways. They should be changed only when there is an indication for such a change. The airway must be greatly respected. Unnecessary extubation and intubation must be avoided. We'll pause right here, right? Oh, man. Let's keep going. It's for the people, right? Always for the people. Tracheostomy wound care. The respiratory care practitioner must be familiar with the basic principles of caring for a tracheostomy wound. After bleeding has been controlled, the major factor is to prevent the area from becoming grossly contaminated or traumatized. The wound should be cared for like any other surgical incision, i.e., it should be kept dry and as free from exudate and secretions as possible. That's why we cover it up, right? Because those secretions, they can get infected easily. That's so important. Thank you for reading with us. Likes and subs. Here we go. It should be kept dry and as free from exudate and secretions as possible. The area should be cleaned routinely with 3% hydrogen peroxide, rinsed with sterile normal saline, and a sterile dressing applied. Cultures need not be taken if infection is suspected, since the area will most assuredly be contaminated with secretions. The tracheostomy ties should be securely fastened using a knot to minimize the movement of the tracheostomy tube and prevent accidental decannulation. Care must be taken to prevent excessive pressure against the wound. When reasonable, attempts are made to keep the area clean and trauma to a minimum. There are seldom significant problems with tracheostomy wounds. We'll pause right here at the top of page 273 of Clinical Application of Respiratory Care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. Shaking it up on YouTube, reading medical material for the people. We can know thyself, heal thyself. Thank you so much. Yes, yes, yes. So grateful and thankful for all that I have now and all that is coming to me. Thank you so much for reading books with us. Eyes, heart, love. We're shaking it up on YouTube, reading books for the people for free, right? And no commercials. We want to give a love and shout out to the elevation and freedom of the Ba and Ka of the great Asada Shakur. Hey. She has been a blueprint of being free. We honor you. Thank you. When you're free to go and do as you wish, when you're free to speak in the love of the ones you are amidst. This is the poetry of life. So thank you for leading your way. Thank you for showing us what freedom is. I can only ask myself to continue on with that energy, showing me what freedom can do. When you're free to come and go, when you're free to just pick up and say, I'm going here, I'm flying there. When you're free to relax and be in peace. That's what she showed us. She showed me. Move the energy That's the lesson of the planets. They're always moving. Just like we're reading in clinical application of respiratory care, moving the secretions, letting them go. This is a form of release. When we can release, then we can accept and bring in the love. So, highest heart love, thank you so much, Asada Secure the Great, showing us black and white rose for you. Your journey for 40 days and 40 nights. And we'll see you in the stars. Let's have a drink of water. Send you off. I want you to have a wonderful day. Happy Friday. Happy Juma. You know I love you. 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 Thank you so much for reading with us. Thank you for breathing with us. Thank you, man. Peace, RC. Man, highest heart love. All right. We will see you soon and reconvene with the closing out of chapter 16 of clinical application of respiratory care. Highest heart love. See you soon. I love you, you. You know I do. I love myself. I love you. Peace, peace. That's right.